medical term, but why we don't want to say testosterone is because there are different types of male hormones, and all of them are involved in that pathology. This hormonal imbalance causes several problems, including irregular menstrual cycles, missed periods, acne, obesity, and excessive hair growth. So the condition was first described in 1935 by two American gynecologists, Irving Stein and Michael Leventhal, and that's why it was initially called the Stein-Leventhal syndrome. So they had observed people, a number of patients who had the classical symptoms that we describe in our PCOS, and they came to realize that it's a syndrome and these patients have the same problems, and they came up with this. And of course, lots of terms have come across, but finally we have settled on polycystic ovarian syndrome. So in this condition, there are the ovaries have small cyst fluid-filled sacs, which develop in the ovaries of people with PCOS due to lack of ovulation, and hence the name polycystic ovaries. Okay, and we're going to see, look and see, does everyone have polycystic ovaries? For them to have PCOS, yes and no, we're going to answer in the course of the presentation. Okay. So how common is it? It is the most common hormonal disorder in women of reproductive age. And women of reproductive age is anything between 15 years. Once a girl gets into puberty, we generally describe it between 15 and 45 years. Okay, though of course it can extend depending on whether one has hit menopause or not. But in that age, it is the most common hormonal disorder. We know other hormonal disorders that you might have come across. I'm sure you've heard of people who have thyroid problems, you've heard of people who have prolactin problems. Okay, you have heard of Cushing's. Those are different type of hormonal disorders. But when you look at all of them, PCOS is the most common in this bracket of women and affects about 5 to 15%. It has a higher prevalence in people with infertility, about 15 to 20%, meaning that out of every 10, you'll get maybe about 2 who have PCOS. So it's rather common. And the prevalence or how common it is varies depending on the race and ethnicity. So that's in the US, they find it's like the normal prevalence of 4 to 12. Europeans about the same. There are some populations in Nigeria that have a higher prevalence. In some studies, it was even going up to 20%. But in the world, some of the highest prevalence is found in South India, where the prevalence is up to 22.5%, even some studies showing up to 26%. So it can be really common in some populations, okay? And who can get PCOS? A woman can get PCOS anytime after puberty and extends all the way. So we have people, different age groups. We have young girls who are pubertal with PCOS, and we have people who are hitting menopause who still have PCOS. But of course, how it presents and how it is different depending on the age. Most people are diagnosed in their 20s or 30s. I'm sure you agree with me, when they're trying to get pregnant. So most people could have had the symptoms for quite a while, but it's when they go and find they're having menstrual problems, they're trying to conceive, that they finally get the diagnosis. The risk factors for PCOS include obesity, having a family member with PCOS, especially a first-degree relative, meaning someone in your lineage, people who have had prepubertal obesity, and some medications like valproic acid, which is an anticonvulsant or for epilepsy, is associated with PCOS. Okay. Okay. Sorry, I'm having a bit of problems with my sliding. So identifying PCOS, it is a diagnosis of exclusion. One of the reasons why many people have PCOS and they don't know is that it looks like many other disorders and people don't think about it. So it is present in people who have infrequent menstruation and signs of hyperandrogenism, which we said is a male hormone. In those signs, and we're going to talk about them. But many other disorders can be confused and have to be rolled out, including thyroid disease, hyperprolactinemia, so a high level of the milk hormone. Thyroid disease is either high thyroid hormone or low thyroid hormone, which we call hyperthyroidism or hypothyroidism in each of them, or a condition called congenital adrenal hyperplasia. There are other conditions that that need to be rolled out, things like adrenal tumors. There's a gland we call adrenal, the adrenal gland, which produces a male hormone. People who have Cushing syndrome also can be confused and could sometimes look like they have PCOS. Despite being common, it is frequently undiagnosed, and people often have to do several visits. I'm sure you can attest to that, to different providers who then maybe diagnose or misdiagnose. One tells you have PCOS, the next one tells you, no, you don't have PCOS. So it is just because it doesn't have a specific test, and there are different types of PCOS. So there are different spectrums. I didn't want to go very medical, but even medically, there are 4 different types of PCOS described, and that confuses. So here we can see a polycystic ovary. A healthy ovary will just have a few eggs, but a polycystic ovary will have different fluid-filled sacs. That's what we were talking about in a polycystic ovaries. So what is the cause of PCOS? The exact cause is not known, but there's evidence that genetics play a role. There are several susceptible genes that have been identified, quite a number, and as contributors to the causation of the disease. That big term means causation of the disease. And not everyone with these genes then has PCOS, and some people have the same genes but display it differently. It is hypothesized that individuals with this genetic predisposition usually get the disease after exposure to various environmental factors which could lead to expression of the PCOS. And the most common environmental factors include obesity, excess weight, or insulin resistance, which we are going to talk about. And also, another big hypothesis is fetal adrenal exposure. What does this mean? Meaning that if a baby exposed to high testosterone or those androgen hormones when they're in the uterus of the mother, okay? So when the mother is pregnant, that has been thought to be a big factor in the causation of the disease. What are the common symptoms? Irregular periods, abnormal hair growth. So the irregular periods, skipped periods, lack of periods, followed by heavy bleeding. Abnormal hair growth affecting up to 70%. It includes facial hair, excessive hair on the body, okay? So that maybe pubic hair is extending, or even in just hairy legs and arms. And for some, male pattern balding. Acne, facial, and on the trunk, meaning on the body. So like you have a bit of acne even on the chest. Obesity. Not all people with PCOS are obese, but majority are obese. Darkening of the skin, patches of dark skin, especially in the folds, we'll look at that, and infertilities are common. And other features of PCOS include insulin resistance or diabetes mellitus, increased miscarriages, obstructive sleep apnea. So you'll find these are people who have reduced oxygen concentration when they sleep because of a bit of obstruction when they sleep. A common, and it's getting more, people are investigating it more and trying to treat it. The diagnosis is usually quite difficult to come up with for obstructive sleep apnea. Metabolic syndrome, which we are going to talk about, and endometrial problems. Neoplasia means overgrowth, or sometimes could lead to cancers later on in life. So we're going to talk about all that. So PCOS accounts for about 95% of increased male hormone. So there are other conditions that have increased male hormone in women, including tumors that have that, or congenital adrenal hyperplasia, but 95% of these people who have been found to have high male hormone most likely will have PCOS. It is responsible for 20% of all cases of lack of periods, okay? And it's responsible for about 75% of all anovulatory infertility, meaning if you have infertility where there is the egg problem, about 75% of the times it's due to PCOS. So menstrual abnormalities, we've already talked about them, that they're usually associated with lack of ovulation. The periods so a period that is lasting more than 35 days tends to be an abnormal period. The normal duration of a period is between 21 to 35 days. So periods that are coming after 40 days are most likely associated with a hormonal disorder, and we've seen in most of these cases up to about 20%, or if there's no ovulation and causing infertility, up to 70% of the time is due to PCOS. Hyperandrogenism, which you said is the increase in the male hormones, 50 to 90% of have elevated androgen levels or those male hormones, we don't always test for them because in our situation sometimes finances are limiting, and if the insurance sometimes they don't always pay. So sometimes, especially when we can see it visually, we don't always test for the male hormone in the blood. And it causes hirsutism. So that is a medical term that denotes facial hair or excessive hair, acne, even on the body, excessive hair in the body, facial hair, trunk or hair, acne, male pattern balding, alopecia. Yeah, because some people don't understand. Hair loss is also can be brought about by the condition, depending on the voice. Rare but can happen. An enlargement of the clitoris. This is all due to if the male hormone is high. Polycystic ovaries. Okay, so here you can see enlarged ovaries which are polycystic. On the scan, this is what we see. Instead of seeing just a few pockets of fluid, these mosses that usually have eggs, we see quite a number. And in the books, it's described as a presence of more than 12 follicles. Though with better scans, the definition is moving to more than 20, but it's not been agreed upon. We're just taking the old criteria. The ovaries are also enlarged with a volume of more than 10 mLs. Usually, you don't need for both of them to be polycystic. One ovary being polycystic denotes polycystic ovaries. And usually, the scan should be done early in the cycle, what we call the follicular phase. So you'll find if you come and we are not able to make the diagnosis, and if you come in the middle of the cycle or somewhere, we might tell you to come again at the beginning of the cycle for proper diagnosis. What is insulin resistance? We've been talking about it a lot. It is, and people have been asking about it in your group. It is a decreased biological response to normal concentrations of circulating insulin and glucose metabolism, resulting in high levels of insulin and, of course, glucose or sugar abnormalities. So what have I just said? So it is when someone doesn't respond normally to glucose. So when you eat and your food is broken down, because the main thing that food is broken down to is glucose or glucose metabolites. Ideally, there's a level, your insulin should rise to a particular level, and that insulin should do something to lower this glucose, either change it to fats, change it to glycogen. So when your body is not responding that way, we say that you have insulin resistance. And what finally happens is that your body keeps on trying to increase an amount of insulin, and that alone can cause problems. So people with insulin resistance, usually it can be associated with diabetes, not for all, but eventually can lead to diabetes. It can lead to metabolic syndrome, which I'm going to describe in a few minutes, obesity. It can also sometimes come when you have infection or severe illness. Some severe illnesses cause an insulin resistance, so you look like you have diabetes. It is also high in people with inactivity and excessive weight, okay? What are the signs of insulin resistance? You know, when I looked at this, I realized many of us have that, have a bit of insulin resistance. Many of us who have a bit of excessive weight. You find we have an inability to focus, increased hunger. Okay, so you've eaten, but 2 hours later you're hungry. Bloating, excessive intestinal bloating. So you're always feeling bloated. You feel excessively sleepy after meals. Weight gain and difficulty in losing weight, especially around the abdomen. Okay, so that's what we call central obesity. Increased blood pressure. Acanthosis nigrans, which is a brown to black, poorly defined velvety hypercoloration of the skin, okay, which I've shown as A and B on the pictures there. You find a bit of dark skin on the neck, in the armpits, between the thighs. Many ladies have asked how to reduce that coloration, and there are all these cosmetic doctors who are trying to help with that. Depression, yeah. I think, well, current life, there's lots of depression, but the condition is associated with lots of depression or low mood, and then increased cholesterol. Okay, so those are all signs and symptoms of insulin resistance. What is metabolic syndrome? So we say people with metabolic syndrome have insulin resistance. It's like a chicken and egg story. But what is metabolic syndrome? It's a combination of medical disorders when occurring together increase the risk of developing cardiovascular disease. Okay, cardiovascular has to do with the heart, vessels, and diabetes. So there are different cardiovascular problems that people can have: strokes, heart attacks, hypertension, cardiomyopathy. So all those are classified under vasculitis, where the vessels are inflamed and not working properly to give a good blood supply to various vessels. So all those come under a big name: cardiovascular disease and diabetes. Okay, so it is a cluster of the following: hypertension, abnormal cholesterol levels, obesity, especially central obesity, impaired glucose handling, which we have already called insulin resistance, and protein in urine, which is a marker that your kidneys may not be working very well. So all these are some things that can be associated with PCOS. So how is the diagnosis of PCOS done? So there's no universally accepted definition of PCOS, hence all the confusion. There are several experts generated diagnostic criteria. So there's no single test that has been agreed upon. And the most agreed upon criteria is called the Rotterdam criteria, which utilizes, so we get a history from you, from the history we can tell you could have PCOS. When we examine you, we find things like acanthosis nigrans, we think, oh, you could have PCOS, or we find that you have facial hair, especially facial hair or acne, points us to that direction. And then we do blood tests. Okay, we analyze blood tests, and then we do a scan and maybe find polycystic ovaries. It has been suggested that the measurement of a single hormonal test, which you call AMH or anti-Mullerian hormone, could be used so that if we find elevated anti-Mullerian hormone above 4.4, we could say you have polycystic ovaries. But the experts or the people forming guidelines have given caution against using only one test, and they still want us to use the Rotterdam criteria. But this is one test that if we find it's high, we think, you could have PCOS. So what is the criteria that we use? You should have two or three of the following: oligo or anovulation. So I had explained oligomenorrhea or lack of. So oligo means less infrequent periods, where your periods are occurring after 35 days, meaning you're skipping periods, you're skipping 1 month, or less than 8 cycles in a year. Okay? Or some people totally have no periods. I've seen patients who have not had periods for 5 years and they're still polycystic. Due to polycystic ovarian, but that is very severe. So if you have that, and then you also could have hyperandrogenism, high male hormone, which we don't need to do our blood test. If we pick that you have excessive hair, male pattern balding, or you could have acne, which are all signs and symptoms of hyperandrogenism, then that is taken as one of the criteria. Or we do blood tests, which shows a free androgen index of high free testosterone, which is a marker of high male hormone. Then also that fits the criteria. Or we do a scan and we find you have polycystic ovaries on ultrasound. Any of two of these three. So if we find you have polycystic ovaries and you come with acne or facial hair, we're almost sure that you have polycystic ovarian disease. And then we roll out many other things. We roll out tumors and things like that. Or if you come with infrequent periods and we find you have polycystic ovaries, we don't necessarily need to document the others. But it is important that we rule out other conditions like the ones I've already said: congenital adrenal hyperplasia, androgen secreting tumors, Cushing syndrome, thyroid disease, hyperprolactinemia. So that's why it becomes slightly tricky in making the diagnosis. So ESHRE, the diagram I've grown, they have a big group, and they have affirmed. So ESHRE is the European Society of Human Reproduction and Endocrinology, which forms a lot of guidelines in fertility treatment. So they have also reiterated that we need to use the Rotterdam criteria, and given caution that in adolescents, we should be cautious about making the diagnosis, because a lot of adolescents, they look like they're polycystic, but they are not. So we take it with caution. So that is what ESHRE added to the Rotterdam criteria. So people are asking about hormonal tests that need to be done, that can be used in making the diagnosis. And this is a whole battery of tests that can be done. So especially when money is not limiting, and in the West, people just tick and do all these hormones. But we are usually cautious because hormonal tests are very expensive. and they might not necessarily add much to the diagnosis, but some of these hormonal tests that can be done, we call them hormonal profile, where we measure FSH, LH, testosterone, thyroid hormone, prolactin hormone, glucose tolerance test like OGTT to check for insulin resistance or insensitivity, fasting blood insulin level, fasting blood lipid profile to check for high cholesterol, dehydroepiandrosterone hormone 17 alpha, all those are produced in the adrenal. So they help us in ruling out whether you could have another reason for the high androgen levels. Transvaginal ultrasound, it is the main criteria. So especially unless the person is a virgin, this is the best method to diagnose polycystic ovaries. So it is by transvaginal scan. We've said polycystic ovaries that more than 12, but criteria changing for 20 to 20 because the scans have become very good. And large ovaries or more than 10 mLs. Polycystic ovaries are not specific for PCOS. Remember, I've talked about teens. And then there are some people with very high ovarian reserve who do not have any other problem and will not say they are polycystic. They have PCOS just because their ovaries are polycystic. Like the diagram below is a polycystic ovary, which found on its own without irregular periods or excess male hormone, then we don't say that the person has PCOS. Some people panic, but that's not. More than 20% of people will have incidental polycystic ovaries without having the condition. Because remember, we said we also need a bit of environmental exposure for that to happen. So, okay, I guess someone is not commenting. Anastasia, am I audible?
Yes, you are. Sorry, I think the person was not on mute, but I've muted her. Yeah.
Oh, okay, great. Oh, I thought it was a feedback.
Okay.
Or maybe I'm talking too fast. I'm almost done. Don't.
No, actually, don't. Yeah, you take your pace, because I know everyone wants to understand as much as possible.
Yeah.
Okay. Okay. Yeah.
Okay. So in the past, PCOS was just considered as a hormonal disorder, but it's known to be a hormonal disorder, metabolic, meaning affecting other things like all your other hormones, lipids, cholesterol, all that. Hormonal psychological disorder that impacts on a patient's quality of life. And I don't think they are better experts than you people on how it affects the quality of life. So it is extremely important to holistically treat people with PCOS and look at other aspects apart from just the PCOS. Early diagnosis is important, and long-term management can help control PCOS so that people can live a healthy, active life and avoid long-term complications such as metabolic syndrome, which we talked about, which can lead to cardiovascular disease and diabetes. I hope I don't sound like a scaremonger, but it's good that we know. And many of us who don't even have PCOS are also at risk because of obesity. Okay, so we need to remember, even after we are done with childbirth and everything, we need to live healthy lives to avoid these long-term complications that could lead to this. And another long-term complication could, of course, be cancer of the ovary if not ovary of the uterus, if not well managed and we don't get frequent enough periods. Okay. Treatment, just like the diagnosis, there's no universally agreed upon treatment. And treatment is individualized based on a woman's goal, okay, and severity of symptoms. So are you 20 and the biggest problem you have is your irregular periods? Are you young and the biggest problem you have is the acne or the facial hair? Is the biggest problem just all these moodiness, bloating, and the others don't bother you? You actually don't mind not getting periods? Or could you be slightly in a situation where you're trying to get pregnant and you don't care about anything else? You don't care about the facial hair, the bloating, but you just want to get pregnant, okay? Or are these symptoms just so severe and causing even hypertension that it's the doctor who decides to tell you that we need to treat this, okay? And treatment methods could be conservative, meaning we are just adjusting lifestyle. We're giving you we're telling you how to adjust your lifestyle so it can be managed. Are we giving you medicine? Are we giving you adjuvants, or are we going for surgical treatment? Okay, so this is what I was saying. It's goal specific, okay, and the healthcare provider and the patient need to work out what is important at that particular point. And sometimes, say, like if you're trying to treat fertility, some of the things that you do, you at the same time, you cannot be trying to treat many others because they could affect the fertility treatment. So you either decide, am I going to treat, are we treating the menstrual irregularities plus the hirsutism or the hyperandrogenism? Those can be treated together. Or is it infertility? Are we treating obesity? That can be treated together with many other things. Is our aim mainly preventing the long-term problems? Is it the metabolic syndrome? Is it the enlargement of the uterine lining? This we see a lot in the older PCOS, okay, where the periods are not frequent enough and they are older and there are some changes in the lining, okay? So the first line, and important for everyone with PCOS, even the lean PCOSs, people say kunonea ndani, it's actually a true thing. You might be lean, but you still have your metabolic indices not right, okay? So you look, everyone tells you, oh, you're so slim, but inside you're not healthy. And diet and exercise are important for every PCOS. Modest weight loss of 2 to 5% of the total body weight can help restore ovulation in many obese patients. Initially, this is after a 4 to 12-week dietary restriction. So about a month to 3 months. People should not give up. The diet for 1 month, give up. No, remember it needs to be, by the time you see some changes. Remember the condition, there's a difficulty in losing weight. So it's not something you do for a week, stand on the scale and give up, okay? It needs to be long-term. A daily 500 to 1,000 calorie deficit with 150 minutes of exercise per week can cause ovulation. Kibet, the nutritionist, will talk to us about these calorie deficits things and what we need to do. That's his area. I'm sure he'll explain much better. What is the effect of diet and exercise in PCOS? So the sex hormone binding globulin levels rise and free testosterone levels fall by twofold. I'm going to explain that in plain English. So we usually have a protein called the sex hormone binding globulin, which if very low can make some hormones become excessive in the body. And that is common in many of the hormonal disorders we have, including PCOS. So if it rises, it binds some of these things like the testosterone just by exercising. So it is a good thing. Insulin and insulin growth factors also decrease, which helps with the pathology of the disease. Don't worry if you get lost. This is just evidence because people have tested this, people who have done this, and notice that even it changes the blood picture. And a moderate amount of daily exercise increases the levels of that hormone by 20%, okay? Decreases by 20%. Let me not confuse you, but it's important. I put some of these things because some questions were very specific. Some of you are very well read and for asking specific questions. So if you get a bit lost, it's not meant for everyone. We still will understand without a lot of the science. So the Androgen Excess and PCOS Society, when it comes to exercise, recommends getting at least 30 minutes of moderate to vigorous activity a day and increasing your activity when you can. So when you start off, aim to start with 30 minutes and then you can increase. And especially if you want to lose weight, then you might need to do more, even up to 45 minutes. For example, some of the ways, because some people are asking, what exercise should we do for PCOS? So these are some of the suggestions. For example, you can incorporate some of these exercises in your daily living. You can do interval exercises, okay, of like repetitions. You can work with a trainer, squats, jumping jacks, lunges, bicep curls, and crunches, okay, and at least do them for 30 minutes, okay. Do interval training. Walk for 30 to 45 minutes a day on a treadmill or outdoors. Outdoors are very good, especially in increasing the happy hormones, the endorphins. And I believe this is good enough for many of us. Walking, or walk jogging. Yeah, many of us can do walk jogging because especially if you're a bit on the heavier side, you need to lose a bit of weight before you do very high intense exercises that can damage your knees and your ankles. Okay, aerobic exercises like step, dancing, boxing, spinning are very good. Okay, so you need to combine cardio and weight training. Okay, for better results. Yoga and pellets also are recommended, but it's good to work with, at least have a consult with one fitness person before you, even as you're going on that weight exercise journey or weight loss journey. So just to reiterate, if you lose more than 5% of your body weight, so say if you're 100 kilos, what is 5%? That is just 5 kilos. You reduce your insulin levels, you reduce your ovarian and androgen production, you reduce circulating free testosterone, and it could induce ovulation. So weight loss is important. The other big question was which diet? That when it comes, people asking for diet plans and many other things. Kibet is an expert in that, but generally, in studies, it was shown that a 12-week energy restriction diet, so this was a study done by the Moran group, clients were either given a low carbohydrate diet or a low or high protein diet. So some people go for low carbohydrate, just carbohydrate restriction. Others go for that low carbohydrate with a high protein diet. And in both, it showed that both diets work, but a high protein diet has more advantages. And Kibet will explain to us whether that is true or not. That's just one study. They have he does a lot of that every day. And in addition, diets rich in antioxidants aid in reducing inflammation, which is part of the pathology of PCOS. So apart from the insulin insensitivity, high androgen, inflammation has been shown to be a big part of PCOS, which worsens many of the conditions we have. So we said it is specific to whatever problem. So how do we manage menstrual abnormalities? Lifestyle change or weight loss of 5 to 10% with structured exercise can actually help in achieving more regular menses. So when people lose weight, their period starts to become normal. There are people who had no problem and then they add just a bit of weight and then they come and we see them and they ask what happened and we tell them it's you are predisposed to, you have PCOS or you have insulin sensitivity, but the weight gain is what has thrown you off the cuff and you're now having irregular periods. Combined oral contraceptives, low estrogen pills, AGA 20 micrograms, may have less impact on insulin resistance. So pills are good. We want to use as low estrogen as possible in the pills, and there are different types of pills. When you come to us, we'll describe the different ones. Not all pills work for everyone because some cause intermenstrual bleeding. Others, you need a pill with something that suppresses the male hormone, like say proteron acetate, which we are going to talk about. So we prescribe the different pills depending on what condition you have. Cyclic progestins can also be used every 2 to 3 months, especially for the young teens, just to bring the periods. So there are patients we see who need to have their periods become more regularized, but because of either personal reasons, religious reasons, fear and myths, they do not want to be put on the pill. Okay. Then for them, we just put them on the progesterone hormone maybe every 2 months, so they can get their period. Metformin or glucophage, which is a drug that is used even by some diabetes, is just an insulin sensitizer, improves ovulation and menstrual cyclicity. So that can also be used. So there are lots of questions about pills in PCOS, and I have been involved in discussions. I've seen it in blogs. The pills are given a bad name. Are they bad? Are they really bad? Are they useful? Okay. But let's talk about them. Combined oral pills are given cyclically, can control menstrual irregularity, so they can make your periods come regularly. They can control hirsutism, the excessive hair, and acne, because they will lower the male hormone, they will lower luteinizing hormone, they would increase estrogen. All these would help in in reducing the acne and the excessive hair. Combined estrogen progestin pills are the first line when fertility is not desired in this young person who is just trying to correct especially the cosmetic issues. They can cause they cause a decrease in ovarian androgen secretion and also from the adrenals. So even for those who are having more of the male hormone from the adrenal system, this can still work. Regular withdrawal bleeding prevents endometrial hyperplasia. Remember I said long-term problems in PCOS include endometrial hyperplasia is a term that means excessive growth of the lining of the uterus, which if neglected can lead to cancer of the lining of the uterus. This is the risk factor for this is people who have very infrequent periods. Remember, we want you to have a period or lining shedding every 3 months, especially when there's no progesterone. Okay, some people ask, what about those people who are using contraceptives that make them not get periods, like those who are using the Depo or have the implant? These people are protected because they are on progesterone. Progesterone makes the lining very thin. So even if you don't shed it, it cannot get abnormal growths. But if you're having high estrogen with no progesterone, which happens in PCOS because you do not ovulate, then that lack of regular withdrawal bleeding can lead to endometrial hyperplasia, polyps, and a risk for cancer. So that's why pills are very important, or something that gives you cyclical bleeding or progesterone to prevent long-term cancer, risk of cancer of the lining. Metformin, this is another drug. I've also seen it in the groups. I've had, it's been given a bad name. But the main concern I have with metformin or glucophage, which most of you have heard about, is just the side effects. Causes a lot of nausea and initially bloating and what, but it's not as bad as people would want to say. And it has a very big use in polycystic ovarian disease. It reduces insulin concentrations and lowers androgens by about 20%, which is really good. However, it does not improve hirsutism, maybe over time. Metformin tends to suppress appetite and slightly enhances weight loss. Not for everyone, but over time can help with weight loss, especially because it corrects insulin resistance. Okay, it's a good option for people with PCOS with obesity. It improves many metabolic abnormalities in PCOS and may improve menstrual cyclicity and the potential for pregnancy. So a lot of people have gotten pregnant by just being on metformin. We use it as a first line for insulin resistance for those who can stand the side effects. The target dose is that of 1,500 to 2,550 per day, but it should start at a lower dose and aim to get there. And if you get the results at a lower dose, then you might not need to get that high up. Or you can, what we do these days, because higher doses have lots of complications, we also combine with some of the new adjuvants that we are going to talk about. What about people whose main struggle is with the excessive hair? We can use local or mechanical methods, including shaving, plucking, bleaching, electrolysis. Eflornithine is a cream called Vanica. Vanica, we've tried looking for it locally. You can get it, but most of them are para importations. It's not as registered in this country. It's not. It's registered, but people don't because it's quite expensive. You might find a tube is about 20,000. I don't know whether you people have been getting it, but it's not permanent, so you need to keep on applying. And maybe that could be one of the reasons why it's not been common. Hormonal medications like oral pills control, especially pills that have cyproterone acetate like Diane. I'm not promoting any brand, but that's the main one. But the other generics coming up, all those help in reducing the excessive hair. Anti-androgen treatment, aldactone and cyproterone acetate. Also, those are aldactone is a tablet that can be used. Treatment of infertility. So people who come with infertility and PCOS, they need to do the lifestyle medications we talked about, weight loss, exercise, carbohydrate restriction, so diet modification, insulin sensitizing agents, which include metformin and others we're going to talk about like minoxidil. Then ovulation induction. Okay, so you've not been ovulating. Then we give treatment that depending on what you have tried before or how severe your PCOS, we can start off with the tablets like letrozole, which is very common for PCOS, or clomiphene, or hormones. Those are what we're calling gonadotropins. So we give injections. A lot of people with PCOS, because they're already self-treated, they've already been given in the pharmacies and it's not working. When they come to us as fertility specialists, we tend to start them on injections because that gets them to ovulate quite well. And there are different strategies for making, if you want you to ovulate for IUI or for natural conception, we give a lower dose. If we want you to ovulate mainly for IVF, then we give the higher doses. Laparoscopic drilling, we're going to talk about it, has a good and a bad name as well. Ovulation induction and IUI, or we can go for IVF. So laparoscopic ovarian drilling, that is surgery, used to be very common. It got a bad name, but does it still have a role in the management of PCOS? One thing is that it should not be used as a first line for treatment because there are safer and less invasive ways of dealing with polycystic ovarian syndrome. It can be an option when some other surgery is required, especially in patients who are not ovulating on simple means like tablets, like clomiphene or letrozole. Okay, we call them clomiphene resistant because there are patients who will not ovulate at all with clomiphene or letrozole, and we see them. So the best way to know whether you're resistant is you get the medication and tracking has to be done. I've seen a lot of patients who are given medication and there's no documentation on whether ovulation ever occurred. So in such kind of patients, drilling can be an option. If you're going maybe to remove scars, you're going to remove a fibroid, and we have a requirement on it should be very minimal because there's a risk of even reducing. Some people who have gone into menopause from excessive drilling. Some people have gotten a lot of scarring, and that has given them a new problem, tubal blockage, damage of the area around, a lot of scarring. That's what we are calling adhesions. Or very sick patients, maybe something else was damaged. Maybe they got a burn. So that's why we do not run for drilling. It should be a last option if it's on its own. Another group of people who might benefit from ovarian drilling are people who live in very remote areas. So say someone comes from one of these remote areas, wherever they're not able to access a gynecologist, wherever there are no scan facilities. So this person could benefit from drilling because these other methods that we are using require a lot of follow-up. It definitely reduces hyperandrogenism, so it reduces the facial hair and improve on ovulation. And also, it's good to remember it's not permanent. So if you are drilling 10 years ago, your PCOS will come back. So initially, for about 3 years, you could have a free period where you're not, you don't look like you have the symptoms, but it can come back and other means needs to be. I wouldn't recommend another drilling because you're going to damage your ovaries and your pelvis. Bariatric surgery is a good option for those who are obese, especially those who are morbidly obese, people with a BMI of over 35 in the setting of PCOS. And it has been shown to reverse a lot of the metabolic as well as the reproductive hormones problems, including hirsutism. So since this is available, and there are even some that don't require, there are some where it is less invasive, just swallowing something. And so bariatric surgery can be an option for those who are not being able to lose weight, or those who are excessively obese, so that they are able, because one thing I appreciate is how difficult it is to lose weight. So even you're trying and it's not, then you work with your provider and see whether bariatric surgery is an option. We must address also the anxiety and depressive symptoms, and people should be screened for anxiety and depression and referred appropriately. Psychotherapy should be done. Antidepressants can be prescribed, anti-anxieties, but the best place is either to refer to a psychologist or a psychotherapist or psychiatrist. Adjuvants, that is what most of us are interested in this talk from the questions I saw. Diet and other things that can be taken, okay? Metformin is treated as an adjuvant, the drug I talked about, because it is not even registered for use in some countries. So it has been used for a long time, and I talked about it and all the good, and I'll talk to you about the way it can reduce all the male, the insulin and the male hormone and bring back cyclicity. So metformin is a first line. Then we have minoxidil, we have CoQ10, melatonin, and acetylcysteine, which is abbreviated as NAC, vitamin D, and many others, turmeric. But I'll talk about a few of those that are have a lot of interest. One of the biggest ones is inositol compounds, and I prescribe them a lot as well. So it's important that we all understand. So there are two forms of inositol, minoxidil, and dichloroinositol. I'm trying to leave out the medical bits about the ratios and things like that. Your provider will guide you on that. So minoxidil is actually part of the B complex vitamins, and it's found to be synthesized. It can be synthesized in the body. It's not an essential vitamin because it can be metabolized from others. It is present in foods such as fruits, beans, grains, and nuts. It's given in good amounts. It increases ovulation rates and improves the metabolic factors. It decreases insulin and testosterone levels and improves and improves the insulin, the fasting insulin, the fasting glucose, the lipids. So it's a very good thing. It improves insulin sensitivity, so it's very good for people with IR, and decreases the LH FSH ratio, which is a marker of ovulation. Typical recommended doses are 2 grams per day. So 1 gram twice a day. Some people go up to 2 grams twice a day, and should be prescribed for up to at least 6 months. By 3 months, we start to get results. So some people take it for 1 month and give up and say it's not working. Another supplement that has been shown to have good results is green tea, especially in overweight and obese women suffering from PCOS, and helps with weight loss, and decreases fasting insulin and decreases the level of free testosterone. N-acetylcysteine has been shown to improve pregnancy and ovulation rates compared to placebo, though no significant changes in miscarriage and menstrual regulation and acne hirsutism. Okay. Others that have had a lot of interest is turmeric, which is an anti-inflammatory and also has been shown to have a role in insulin resistance, and CoQ10, which is also an antioxidant. Okay. One thing that we know is that pregnancy after the client conceives, pregnancies in people with PCOS are associated with quite a number of complications, including miscarriages and early pregnancy losses, gestational diabetes mellitus, preeclampsia, and an increased rate of cesarean sections because of distress, large babies. Metformin has been found to have some benefit, though there's no consensus. Not everyone agrees, but the best thing is to optimize. Even the patients who come, they're full-blown PCOS, and they want to conceive immediately. I believe that we need to optimize the conditions, the metabolic disease, even before we conceive, to avoid some of these things, because a lot of people with PCOS will conceive, but they end up in miscarriages, up to 20%. Okay. So in conclusion, the comprehensive management of PCOS requires multidisciplinary treatment and requires a team that includes a physician, a gynecologist, a psychologist or psychiatrist, and a nutritionist. Thank God today here we have a bit of a team. It should be a patient-centered approach. Education and counseling are important. Understanding your own condition is the most important. Appropriate referrals are important, okay, to different providers. Remaining up to date with the newest advances is important. And encouraged to join support groups. Thank God you're already in a support group. I'm sure that has helped a lot. Okay, thank you. So.
Wow, thanks very much, Daktari. Yes. All right. I had introduced Nutritionist Kibet. Do you have a presentation, or we go straight to the questions?
Good morning, all. I think I'll do a bit of summarize presentation,
Okay.
then direct the questions.
Okay.
Okay, today I'm the luckiest guy to be in this group. My name is Willy Kibet. I'm nutritionist by profession. So I'm happy to have joined you today in the morning, at least to present something, because polycystic ovary syndrome is more related to nutrition, and these are really affected a lot of women. And I'll try as much as possible to give you points that can be beneficial to your health, because generally it's about our lifestyle. Remember, how does this one relate to nutrition? It relates to nutrition in terms of the insulin resistance. We understand that insulin is an hormone that is responsible to convert your glucose for fat for storage. So once you have insulin resistance, means that your sugar level from the food that you eat cannot be converted for fat for storage. So the main key thing is, what do you do to make sure that at least you're able to utilize that sugar level so that it might not lead to weight gain? And we have realized one contributing factor of this PCOS is about the weight gain. So we have to look in terms on how we can manage PCOS in terms of weight loss. So how does it relate? This is how does insulin resistance
Count
sorry.
number.
So how does insulin resistance relate to PCOS? So this is when body cells stop responding to insulin in a normal manner, resulting in the insulin blood levels to shoot above the normal. So it means that that is the energy from food cannot be used to for fat for storage. So this one will lead to weight gain. So how does it relate? This is by eating an healthy diet. And remember, high insulin levels also mean that your body is storing more fat, leading to weight gain. So patients with PCOS experience a slower metabolism rate than a normal, making it difficult to control food cravings. So how metabolism, we relate in terms of the metabolic age, where you find that there are machines that measure your metabolic age. So when you find that your metabolic age is above your age, that means that how the body is unable to utilize the food that you're eating. So you're eating too much than what the body is able to use. So first of all, you try as much as possible to increase your metabolism, so that at least the body is able to utilize everything that you are intake. So the main key thing now, when you have the insulin resistance, so this one will lead to, when what will do is insulin resistant, the body is unable, the body will convert all your glucose for fat for storage, and that is the time you can lead to weight gain. So the main key thing is to control your weight so that you're able to control the PCOS. Now, the most key point that I'm here today is we have to look in terms of the food. So let me not go to what the details, but now we can go to food straight. So we have foods to avoid, we have foods to increase, and also we have anti-inflammatory foods, and we have foods to avoid the inflammatory foods. So the main key things is, what are the foods that can cause this PCOS or weight gain? It's unhealthy lifestyle. Remember, that is our daily routine, and we have to be watchful of whatever we are going to take, because remember, there's an Egyptian saying that a quarter of plate is what makes you healthy, and 3/4 of plate is what make you go to nutritionist. So if you're able to control your portion, if you're able to know the time to eat, if you're able to know what's the best time to have certain kind of food, then it will be easy for you to control this condition. So now I'll go to foods to avoid, because that is our major pack that we always face in our lifestyle. So food to avoid are sugary drinks. Sugary drinks, we have come to realize that we as Africans, we love shortcuts of where we want ready food to eat. So sometimes we go and have like Del Monte, bucket juices, we go to chocolates, we do ice creams, we go to, and so those are the things that will add you excess sugar in the body, and that excess sugar in the body will be too much than what the body can utilize. So this one will lead to storage. And also again, we have fried foods. These, we are in town sometimes, and the only option that you can eat there is going to fries. So we should try as much as possible to cut on fries. Make sure that you are eating food that are less in fat content. Also, we have processed meats like sausages. We love sausages. We love samosas. We love hamburgers or hot dogs. So those are the things that can contribute to this weight gain. So try as much as possible to cut from the diet. Then we have refined carbohydrates. For example, the white bread, the pasta, or the food that are processed. The refined means that there is no fiber. So that means the digestion is very quickly. And remember, at certain point in time, the body needs certain amount of sugar. So if these food are very refined, it means that their digestion are quicker, and it means that it will release instant sugar. So instant sugar means that that sugar will be too much in the body, and now the body will resort to converting it for fat for storage. So that is our trouble. So try as much as possible to have unrefined carbohydrates. For example, ugali. If you can go to Shago and bring the one that we normally take to the portion meal, that one is better. Don't go for this grade 1 or the processed one that they have removed the fiber content. So the advantage, even if you ask about brown ugali, there's no brown ugali, but what you can do is go to portion meal, just meal the normal way that we used to meal long time ago, and have that one. So that one will act as brown for me. But when you go to supermarket, pick up brown ugali, I don't really trust it. So try as much as possible to do it. Now, the second thing is about processed food. Remember, when we do a lot of processed food, the fiber content is a bit low, and the sugar levels for processed food is high, because when you can see the nutritional value over there, you realize we have sugar, we have carbohydrates. So sometimes you can be told that this one is low in carbohydrates, but in realistic, you have not checked the energy value or the energy content per 100 grams, and also you haven't checked the sugar levels. And the last one is carbohydrates. So those are the things that you are supposed to be checking on your labels. So when you realize the energy value is high, just know that this one is not a low carb. So don't go for things at supermarket that are written low in carbohydrate or something. I normally say that you need to trust yourself, you need to trust the source. So if you are sure this one is low, if you are the one who is cooking, if you are the one who is going to the shamba, have this maize, take to the portion meal, that one is more better than even going to supermarkets where you just believe the words on the labels, but in realistic it's not the same thing, because we know these are issues that are affecting everybody. So if I make a brand that can be satisfactory to people's eyes, then I get a lot of money. So be watchful in whatever you go and choose at supermarket. Now again, we should try as much as possible to avoid foods with saturated fats, and then we have dairy products, e.g. the cream, the cheese, the fatty red meat. So sometimes you need to be so conscious, because we realize that we normally do take a lot of saturated fats. For example, we have saturated fats and unsaturated fats. Even if I tell you that go and do the salads, remember these salads again from vegetables oil are saturated, so you have to be conscious. The one that are better in terms of the saturated fats will be mono unsaturated, and we have the poly unsaturated. So whenever you are choosing a brand of a cooking oil that you want to use, make sure you check the mono unsaturated, that those are the best one. And the mono unsaturated will be olive, and we have canola. If you're cooking on high heat, you can use canola. If you're cooking on low heat, you can use olive oil. The second best will be polyunsaturated. That will be the Elianto, the sunflower. And also we can include the coconut oil and avocado oil. So those are the best. But now when you come to these fresh fry, we have Rina, we have Ufuta. Those are saturated. So whenever you are trying to use it, make sure that you use in terms of the little. But remember, in terms of the cooking oil is only advisable when you use to cook vegetables, because vegetables need fat soluble vitamins. So it needs fat so that at least you can absorb the vitamins and also the nutrients in vegetables. But when you're cooking things like meat can cook itself. Get the point? When you're doing chicken, cook with its own fat. When you are doing other things, you can do the boiling, you can do the steaming, you can also do the grilling, so that at least we can minimize the fat content that you are ingesting. So try as much as possible to control that. Remember, not everything is safe. And because of the chemical alteration, it has affected a lot of these things. Then also we have the anti-inflammatory foods that the same thing, that is the sugars. So if you are a sweet tooth, that is another problem, because you cannot control the sugar. So remember, it is not about the control, it's about how you think. So it's not hard to leave the sugar. So control your brain, control how you think, control how you perceive things. So those are the key things that you can try as much as possible to alter. You realize that as other people, you are telling them to control the wheat intake, they tell you that I cannot survive without wheat. So the main key thing is how you control your mentality. That is the first thing. And again, try as much as possible to avoid alcohol, because that one will give you excess energy, and excess energy means that those are empty calories that will lead to weight gain. So try as much as possible to avoid them. And we have the margarine, the short life, and also the snack foods, the junky food. Try as much as possible to control and avoid them. Now, foods that you can increase on your diet so that at least you're able to control all these. We have fatty fish. For example, the tuna, the sardines, and the mackerel and the salmon. We can do a lot of vegetables, because vegetables, they are good in antioxidant and also anti-inflammatory. So vegetables will be key, because you can, when you look at their sugar levels, it's much low in sugars. So you can increase as much, be friend to your vegetables, eat as much as you can, because we don't have a problem in terms of the sugar levels. Then also we have the legumes family and the lentils. So the legume family, these are plant protein. But again, plant protein depends on how you combine. So when you are doing the plant legumes, that is the njahe, the minjis, the kamande, the lentils, make sure you know the right combination, because if we have rice and beans, that is a wrong combination. If we have chapati ndengu, that's a wrong combination. So when you're having anything to do with plant legumes will go with vegetables only, because plant legumes are high in carbs than the protein. So if you are going to take with another carb, that one will be carbs overload, and that means carbs overload will lead to weight gain. So when you're having anything to do with plant legumes, eat with vegetables. When you're having carbohydrates, do carbohydrates with vegetables and maybe with a small amount of animal protein. So you have to be key in how you combine that meals. The second thing is about nuts and seeds. So we can also increase the nut and seed, because also nuts has antibodies and also anti-inflammatory. So in nuts, what are the best nuts? We choose the best nuts. Now, when you're having things like the cashew nut, the groundnuts, and the peanuts, those are substitute for a meal. It's not a snack. So the ones that you normally put on your table and snack in between the day, that one is wrong. When you're having peanuts, cashew nuts, and groundnuts, it's in the morning, but it should act as a substitute for a meal, because it gives you about 18 to 20% of carbohydrates. Now, when it comes to snacking period, you can do the macadamia, you can do the almond, walnuts, and hazelnuts. These give you about 3 to 5% of carbs. So these one are among the saviors in terms of the snack content. And also we have fruits. The challenge with fruits is about the sugar levels. So we have fructose. Now in fructose, what happened with the fructose? Fructose is a good stimulant to insulin hormone. So it means that when you do a lot of fruits, it can lead to the body, if you now when the fructose is high, normally stimulate production of insulin, means that sugar level will be converted for fat for storage. So make sure that you're able to control the fruit intake. You choose the ones that are low in sugar levels, and you try as much as possible to avoid the ones that are high in sugar levels. So for this one, I don't encourage on blended juices, because of their sugar content. When you blend fruits, what happens is it's like you are semi-digesting to the body, because the digestion will start on the stomach. So we are avoiding the fiber content that you need to start it on the mouth while you're munching that food. So try as much as possible to avoid the blended, because when you blend it, that sugar levels is readily available. So the body at that instant will take whatever it requires, the rest go for storage. And also avoid fruit salad. When you combine different fruits together, different fruits give you different amount of sugar. So that sugar at point in time will be too much for the body, and it will lead to conversion for fat for storage. So when you're having a fruit, eat one fruit at a go. Don't do combination. Don't take blended juices, but you can have a smoothie. A smoothie means that you can do different types of vegetables, like around 4 and one fruit inside. And the best fruit that you can take will be the green apple, not even the red one, because of the cellulose and the fiber. We have the melon family, that is the watermelon, sweet melon, thorn melon, red melon. We have the berries family, that is the blueberries. We have strawberries, we have raspberries and blackberries. Those are options. And then we have the citric family, that is the oranges, lemon, tangerine, and lime. Then we have avocado, pawpaw, and kiwi. The ones that you should try as much as possible to control are mangoes, bananas, pineapples, dates, and grapes. Those are high in sugars. So when you're having those, the ones that are high in sugars, please eat with vegetable salad, so that we're able to control the effect of sugars. Again, what I can add on that is how you combine the foods. This is the time now you can pick your pen and write something, because I just want to give you on how you can plan your day from breakfast till evening. So if you are ready to take notes, this is the best time to take. So now, choosing a diet for this syndrome, it is normally based on two things. You base your diet in terms of the metabolism, and you base your diet in terms of the activity level. So when your metabolism is very effective, that is the time you have a meal. When your metabolism is very slow, that is the time you control your portion. When activity level is very effective, that is the time you reward yourself. When activity level is very low, that is the time you punish yourself. So those are the factors that determine what you can have, what you can take per day. So the main key things you look at those, that will determine what you will eat. Now, when we base on this, your metabolism is always very effective early in the morning due to overnight fasting. As the day goes by, the metabolism starts slowing down. So the best time to have a heavy meal is early in the morning. The best time to miss a meal is towards the end of the day. So for breakfast, I'll give you roughly around 4 options to play around with. So the first option will be real food. That ugali or that rice you are supposed to have a dinner and go to bed, you can have it in the morning. In the morning, you can eat as much as possible, because we take advantage of how metabolism is very effective. And remember, your organs and cell need that glucose. So if you take in the morning and again you'll be working during the day, then that one will be awesome. So let's take the first option as real food. You can have that carbohydrates or ugali, for example, take with the vegetable and maybe some small amount of animal protein. So that one is our first option. The second option, we can do the complex carbs. That is the sweet potatoes, the arrow, the cassava, the boiled maize, the githeri, the mokimo with a cup of tea, so that we're able to avoid the gluten or the wheat products. Because remember, gluten or the wheat products, they contain a nutrient called gluten. This gluten slows down your metabolism, and we talk about how to increase metabolism. So when the metabolism is slowed, or when you take like 2 slices of brown bread or normal white bread, you have ruined the rest of the day. The body goes to storage mode instead of utilization. So whatever food you'll be taking during that day will not be so important to you, but will be converted for fat for storage. And that's how you will increase the weight, and end product will lead to this condition, the severity of this condition. So try as much as possible to control the wheat products, but have this complex carb, because they're high in fiber content. So that means that the body is unable to digest immediately. To take long time to be digested, and that slow release of sugar will be an ideal. That option can be a boiled egg, but not more than 4 in a week because of the cholesterol issues. And then the last option can be cereals, and in cereals you do oats or cornflakes, but not more than 3 times in a week. Try to avoid the Weetabix and the muesli, because those are wheat products. And you can enrich your breakfast by having akina cashew nuts, groundnuts, and peanuts. Now, when you come to 10 o'clock or 4 o'clock, that is our snacking period. In our snacking period, focus on: one, take water, because that is our first snack. I normally call it as a snack, because sometimes thirst can come in form of hunger, so you may end up eating instead of drinking water. So have that 500 ml of water before you decide on taking any other snack. So if you're okay, then please don't take anything. But you have not okay, then have one fruit, the one that I've mentioned before. That is our second option. Third option will be plain yogurt. If it's early in the morning, the plain, the natural, or the Greek yogurt, or the bar yogurt. If it's early in the morning, 250 ml. If it's afternoon, around 150 ml. Then we'll have the last option for snack. That one will be the nuts, and the nuts for 10 o'clock will be macadamia, almond, walnuts, and hazelnuts. Cashew nut, peanuts, and groundnut, those are breakfast. Now, when you come to line time, focus on activity factor. So if you're active, you reward yourself by having a half cups of whatever you had in the morning. You moderate your protein, but you double up the vegetable. If there is no exercise, you are just seated. If there is no exercise, you are just seated at the office please no carbs, no plant legumes for lunch. So try as much as possible to do something more than that. So when there's no exercise, please you can do vegetables plus a fruit, or you can do an animal protein plus vegetables. Now for food combination, again, is another things to introduce. So when you're having anything to do with carbohydrates, eat carbohydrates with vegetables. And when you're having anything to do with plant legumes, eat plant legumes with vegetables. That one will be the best option. Now, when we go to dinner, the first option is miss a meal. If you cannot miss a meal, then you go to the second option, that is vegetables only. If vegetables are not enough, then you can do a vegetables plus a fruit, for example, a smoothie, or you can do a vegetable salad and maybe an avocado, or the list that I've given you. But the day you are very hungry, take a small amount of animal protein plus a vegetable. But remember, points to note, carbohydrates and plant legumes last up to 3 p.m. The second thing, animal protein is up to 7 p.m. A fruit is up to 8 p.m. Vegetables is anytime. So that is how you control your daily activities. And remember, we need to avoid the consistency where you say that I must have breakfast, I must have snacks, I must have lunch, or I must have dinner. The main key things you play with how your metabolism and activity level. If you are very active, you can have a 3 meal. The day you are not active, you can have a 2 meal. And the day you are inactive, you just in the house, you can have a 2 meal. So fluctuate basing on that one. Try as much as possible not to have a consistent, but you can bring in consistency so that the body cannot adapt to a certain criteria. Same thing to apply to exercise. Exercise is very key because that determines how we can use our glucose level in the body. We know we have this insulin resistant hormone. And so what do we do to make sure that we're able to utilize this energy level? So we increase our work rate, we increase our exercise. So keep on exercising. I normally encourage an exercise, an outdoor exercise, where you can go and jog around, try as much as possible to control or to increase your step, challenge yourself on a daily basis. So we need to increase aerobics and cardio. Avoid weightlift as much as possible because that one will not define who we are. Weightlift will come after you achieve your target goal. So try as much as possible to increase your exercise in terms of aerobics and cardio. Thank you. Now we can go to questions.
Okay, that was really great. Thanks a lot. I'm sure everybody has learned. So we will go straight to the questions. I'll just be reading the ones already on the comment section. Okay. So I think this one is for you, Daktari. Daisy is asking how safe it is for someone to do vaginal steaming. Because it's highly advertised on the internet. Yoni pulse, is vaginal steaming. So how safe is it for? Yeah, because they claim that it helps to improve fertility.
Okay, thank you. First, let me commend Kibet. I've learned a lot even in that. It's very practical. Now, let me go to the vaginal steaming. It has not been documented I'd hate to destroy someone's business who sells yoni pearls or steaming things. But the vagina is one place that needs the least interference, because the more you interfere, the more you interfere with the bacteria, the lactobacilli, that actually have a very critical role in reducing infections and inflammation, and that can destroy your fertility. A big thing that has come up in fertility is actually the use of probiotics and the balance, the bacterial balance. So anything that interferes by steaming, by steaming you'll be killing all. I don't think there's anyone who survives steam, or who survives some stones that are producing something. So it's best that you avoid. Just go au naturel. Wash with water. Be as conservative. Reduce perfumes in that area. Wear your cotton underwear. When you don't have to, don't wear any. Just allow for aeration. Okay, over to you, Anastasia.
Okay, thank you. There's another question. And sorry, I've called you Kigen instead of Kibet. Apologies for that. So there is another question on what's the hope for a PCOS patient who is in her mid-30s of ever conceiving?
Okay, a lot of hope, a lot of hope. This is a conversation I have with lots of patients. I'm not encouraging anyone not to get treatment early, but PCOS can be a blessing, especially in slightly higher age. Because remember, it's a disease of abundance. Okay, the egg quality might not be the greatest, and that's why we give lots of antioxidants and we give all these insulin sensitizers just to improve on the egg quality. But remember, a lot of the PCOS patients have a slightly higher reserve than normal patients. So I would tell this person they have a lot of hope. They just need to do the best they can at that point. And there's a role of there's something that is also coming up and we're doing a lot of, which is called cryopreservation or egg freezing. Say you're worried you have this condition and you don't have a male partner and you're worried about your future fertility. You can always get your eggs frozen. You can come to us. We do a stimulation. We keep the eggs for you because definitely they will be at a better quality when you're younger than when you're older. So when you're older, they will still be more than normal people, but the quality will be low. So I encourage you, lots of hope, but do the right things.
All right, thanks a lot. I think in line with that question, there was a question on ovulation. Do PCOS patients ovulate normally? Somebody who is experiencing a normal cycle. And also there, in reference to the same, there was a question whether people ovulate when they're not having their periods.
Okay, that's a very good question. And I had that slide, I think I tried to shorten the presentation, it was very long. One, people who have, you still can have an ovulatory cycles. Someone with PCOS can even have a period, but not have ovulated in the cycle. And that is found to be up to 20% of cases. And it's almost always true that you're not ovulating normally if your periods are not regular. And that is one of the reasons why people with PCOS have fertility problems. So problems with ovulation is the main thing in PCOS. So in PCOS, the main thing we have to treat is ovulation. Make sure you're ovulating. Give medication to improve the quality of the egg, but in most cases, just helping the patient ovulate will restore their fertility. I hope I've answered that question because I've seen a lot of confusion. People confuse PCOS with endometriosis, with blocked tubes, but PCOS is mainly an ovulation problem when it comes to fertility. So there's abnormal ovulation in most of PCOS cases. But these people with very mild PCOS actually ovulate quite a number of times in the year. And if they're not careful, they'll get unwanted pregnancies. So because I've seen you tell a young lady that she has PCOS, she goes and reads and hears that there's infertility. She goes off her methods and the next time she comes with an unwanted pregnancy. So we still have to take care of both sides. Okay, Anastasia?
Right, thank you very much. I think this one is for you, Kibet. Someone is asking, is there medication for losing weight, and is it even recommended to use medication for losing weight?
Okay. Thank you so much for asking me that question. Now, the problem is I don't believe in medication for losing weight because remember, this medication, the ones that they normally sell at market price, and actually is not for our beneficial because you realize they're using tablets for losing weight. How does this the tablets relate to losing weight? It's because it will prevent the body from absorbing that or converting that food for fat for storage. But the main key things it will lead to inadequate nutrients intake in the body, and this one will impact your life in your future. So it can be a quick fix, but by the end of the day, all of them will come back to haunt you. So the main key things, you didn't gain that weight in one day, so you should focus on your nutrition, you should focus on your food, you should focus on your exercise. That is what I can advise you, but don't go for these tablets all around. It is not something that can justify or can be a good thing for your future. You can get a weight loss, but that one will last only for a few months or a few weeks. So the main key things, try as much as possible to cut your weight, maybe like at least 1 kg per week. That is the most consistent one. So don't do the shortcut. Shortcut can give you a result, but by the end of the day, that results will come back, and even you can even add more than what you had before. So the main key thing, focus on your food and focus on your exercise. That is the main key thing. Thank you.
All right, thanks a lot. And maybe in line with that, then is things like intermittent fasting are recommended?
Now, in intermittent fasting, the main that can be so much recommended will be 16/8. And in this 16/8 means that we have 16 hours of fasting and 8 hours of window period of eating. But I've restructured in such a way that when it comes to intermittent fasting, you restructured basing on what time to eat, because in intermittent fasting, basically it can be a 2 meal, it can be a 1 meal, it can be 18/6, it can be 24/0. So that one meal will be 1 meal per day. So the main key thing in terms of intermittent fasting, the one that can be realistic will be 16/8, and that one you can do it for a long time without bad effect. But the ones that are shorter, remember that window period, the body will be broken down to the ketosis will happen. So the main key things, try the 16/8. And when it comes to that, so alter your always change the shift. Don't eat at the same time, because eating at the same time, the body gets to adapt. So after 1 month or 2 months, the body has adapted to that situation. So today you can decide, you base your meals in terms of timing. So if I'm having a 2 meal, so for example, today is on Saturday, so I can eat maybe between 6 in the morning to around 10. That is our first meal. And when you're having that first meal in the morning, just do your carbohydrates, a protein, and a vegetable. Then the next meal will be around afternoon. So that is the time also you get. You can do either vegetables only, you can do vegetables plus a fruit, or animal protein plus a vegetable. Now the next day, don't eat between 06 to 10 a.m. That is the time now you can have between 11 to around 1 p.m. And that is the time you can introduce something like a plant legumes plus a vegetable. And maybe you can have at around 7, you have only vegetables only. Then you proceed to another day, then you can say that let me have by around 3 in the between 1 p.m. to around 3. So that means that you can only qualify for animal protein plus vegetable. Then now at dinner you can have just a vegetables plus a fruit. So intermediate fasting, don't maintain the same routine. Try as much as possible to fluctuate basing on time. Don't maintain the same times every time. So that is what I can recommend. Thank you.
Oh, thanks a lot for that. I'm sure everybody has heard. Back to you, Daktari. Someone is asking, what treatment is there for treating acne and damaged skin in the upper arm?
Okay, thank you. So for acne, especially associated with PCOS, it is mainly in lowering the male hormone. A lot of the things we have talked about, like it needs wholesome treatment, weight loss. That was we said, weight loss and exercise is a mainstay. Then increasing insulin sensitivity by whatever, either we are giving, if you have it, either giving minoxidil or glucophage. And then if you're not trying to get pregnant, we then can put you on some pills that lower the male hormone, like something like cyproten or acetate, and or even the other pills like even the means. But if you're trying to get pregnant, then it may not work at the same time, and then you'd have to just treat it. You see your dermatologist, and they put you on treatment locally that then can reduce the acne. When it comes to damaged upper skin, I'm thinking that is acanthosis nigrans, the one you're seeing, the darkening. There are different things that the dermatologist can do for you. And I think for both conditions, it would be best that you see your gynecologist and also make an appointment with a dermatologist. Self-treatment might not be as good, because you have, for the face, you have to be very careful, because you don't want to get scarring, but it's a wholesome treatment. Over to you, Anastasia. I hope I've
Alright.
answered. I don't have a one answer, but it's the whole PCOS treatment that is required.
All right. Okay. Thanks for that. I think the next question is a three question in one.
Mhm.
So they're asking what is the cause of ablated ovum? And then second, what is the best family planning method for someone with PCOS and one blocked tube?
Okay, great question. So the main reason why we get blighted ovums come is usually an abnormal or can we say a weak embryo. We try to use the word weak because people don't like to hear of abnormal embryos. And this is usually due to an imbalance in the chromosomes during division. So that you ovulate a normal egg and you get a normal sperm. But during the mixing and the separation to give the chromosome balance for the new embryo, because remember we are different. The embryo will have a different genetic composition from both the sperm and the egg, and that mixing is done in a particular way. But because of either low quality weakness in the egg or weakness in the sperm, there can be an imbalance in the embryo, and it will implant the sac, the part that grows the sac, the amniotic sac, and the placenta continues to grow, but the embryo dies off early, and that is how we get a blighted ovum, meaning that there's no embryo being found in the sac. Rather common, even in people with PCOS, because we say there's a bit of problem with the quality of the eggs. The other common reason why people get blighted ovums is age. Older people have poorer quality eggs, and that's why I was saying even with PCOS, you could be lucky to have quite a number of eggs later on, but the quality could be poor, and you still could have more blighted ovums. But it is something we don't do too much. You just usually by the next time you might ovulate a normal egg, and not too much to be worried about. About contraception for people, for someone with PCOS with one blocked tube. So there we have to consider that this person has a blocked tube. So something like an intrauterine device that can predispose you to even an ectopic could be something you could want to maybe avoid. The best methods for people with PCOS are the estrogen progesterone combined methods, and that includes the daily pill for those who are able to remember to take them. For those who are poor with the pill, then you can use the patch, which is a weekly patch that will give you cyclical bleeding, will manage the acne and the hirsutism. So we really like the estrogen progesterone combined methods, the pills or the patch. Okay. Over to you,
Okay, thanks a
Anastasia.
lot. All right. Thank you, Doc. I think this other one is, I believe for you, Kibet. So I think this is very common with a lot of us with PCOS. How do I do away with a big stomach, which doesn't seem to go away? And
Thank you so much. Sorry,
no, you
Anastasia.
can proceed. You can proceed.
Thank you so much. Now we have something called visceral fats. Remember, Daktari talk about the fat content. These are the fat content around our tummy area. And remember, these ones does occur over a long period. Sometimes maybe you are unable to remove it immediately after pregnancy, or sometimes that you may find that you have taken a lot of sugary and also deposition is around that area. Again, we normally focus on food, forgetting about stress factor. Remember, when you are stressed, there's this hormone called cortisol hormone. So, and cortisol hormone is a stress hormone where you tend to go for sugary things or the carbohydrate things, and the deposition will be around that area. Now, when you have cortisol, also what happens is the body will look for fat content around other areas in terms like the arms, the upper body, and deposit around the belly. So those are the contributing factor for that. So how do we remove this one? Remember, we need to introduce exercise that deals around that area. For example, the sit-ups, for example, the press-up, the hula hoops, the jumpy jacks, and also running that involves around all the body. So increase Your exercise will also help. The second thing is you control the intake of meals, because remember that deposition will be anywhere. So others choose deposit on that area. So the main thing, you need to control your portion. And controlling your portion means it's not a must you eat a small amount of meals. Sometimes you can increase, sometimes you can do less. So in terms of the portion control, don't maintain a plate concept method. So the main key things is you know the right time when to have these things. If it's carbohydrate, you say that you can do it in the morning. Doesn't matter about the portion. If it is by the end of the day, try as much as possible to control the portion. But for breakfast, eat as much as you want. So we need to create space. And talk about metabolic age. Now, if we're able to improve our metabolic age, it means that if I'm like at 38 years old, and my metabolic age is at let's say that 48 years old, so it means the food that I'm eating is for 38 years old, but the organs and the cells can only take an energy of a 48 years old. So when you look at these people, 38 years old is more active and a 48 years old is less active. So when we combine these two and see what's the best thing to do, so it's either you are 38, so the means that you're eating, no matter how tiny it is, the body is used to that one. Now, the body can only utilize a meal of a 48, so we have retaining. And now retaining that amount of energy means that can be deposited around our belly fat. So how do we improve this one? It's just by improving your metabolic age. Is either you decide to have a meal in the morning, that one will be the best thing. So the main key points to how to work on your metabolic age, because we need to bring that 48 to less than 38. So if you are like a 38 years old and metabolic age is reading 35, it means that your intake is for 38 years old, but the body will be able to utilize a meal over 35. So it means that we have a diversity, and a diversity means that the body has to look for alternative source on how it can source that energy to fit at 38 years old. At 35 years old, actually. So that means that the body will have to look for glucose or store fat around the belly areas and other areas of the body. So we need to improve metabolic age. So the main key thing, improve your metabolic age. How do you improve your metabolic age? Number one is by increasing your cardio, by increasing your exercise in terms of the cardio and aerobics. In terms of the exercise, make sure that you can do in terms of steps. So today we are having 5,000 steps. Tomorrow we can do an 8,000. Another day we can do a 4,500. Another day we can do up to 10,000 steps. So always challenge yourself on a daily basis. I normally love the exercise that you can pant, you can sweat. You can find that you are straining to gaps for that air. That is the best exercise that can help us improve our metabolic age, because that is the main key thing that determines all the aspect, that determines the body fat storage, that determines the visceral fat storage. So exercise is the first option. The second option is by increasing water intake, and increasing, because when the body is hydrated, the metabolism is very effective. When there's no water in the body, the metabolism is very slow. So if we keep our metabolism active, to maintain that metabolism active, you need glucose. So if there's no food in my stomach, then it means the nearest source of the glucose will be the body fat and the visceral fat, and that's how we'll be losing our belly fat. The second thing is by increasing food that are high in fiber, for example, vegetables, because remember, fibers are hard to be digested in the body, so it will take time to be broken down. So if we take a lot, it means that the body has to look for another source to make sure that it can help the metabolism to digest this fiber content. And now the nearest source will be the body fat and the visceral fat. So that is how we'll be able to lose. The third thing is about avoiding the wheat products, because wheat products slow down your metabolism. So try as much as possible to avoid them. Increase the food that are high in fiber. Then the last option is management of stress. Those are the key factors that can help us burn the belly fat. Thank you.
Oh,
And
thanks for the comprehensive answer. Asante sana, that was good. Thanks.
Karibu.
All right. The next question is for you, Daktari. Someone is asking, I have been on statins and glucophage for a month now. Then I have letrozole to take on the third day of my period, but just yesterday I only spotted. So my question is, can I still take letrozole? I think, yeah, this happens a lot, doc, whereby maybe you're told to take letrozole on the second day or the third day, but you're only spotting the real period hasn't started. So what are you supposed to do in that instance?
Okay. So remember, a lot of people with PCOS do not get regular shedding. The good thing is that because the cycles are very long, and even if you've been told to take on the second or third day, there will be no how can I say, there will be no indigenous egg recruitment. I don't know that I've lost you. Why we tell people to start the medication for ovulation induction early in the cycle is so that the body itself has not chosen an egg. We want to try and influence that so that you get better ovulation. But in PCOS, because the cycles are very long, you can even start that on day 10, 15 without any problem. I'm not advocating for that, but what does that mean? It means that you can keep on waiting for a proper period to come. Because this spotting, we don't know whether it's a period or it is some abnormal bleed, and then you start, it confuses everything, and then that will delay one cycle. So I'd urge you, just wait, see whether the period will come normally. If it's not coming normally, then see your doctor to give you a progesterone to cause a withdrawal bleed so that you start your period at the time of the withdrawal bleed. Okay? So I don't know, that would be the best option for me because you can always see the doctor. If say you give it another 3, 4, 5 days and the period is not coming normally, it means it was not coming. Just get a progesterone prescribed, get a period, and then start on the third day, second day or third day of that bleeding. Over to you, Anastasia.
All right. Thanks, Daktari. Yeah, that's very helpful. Okay, okay, this one is a bit long, but I think maybe, yeah. So thank you for the great presentation. I have a question on diagnosis. I have regular periods, but check out on hirsutism, polycystic ovaries, and also infertility. My prolactin levels are also higher than normal. AMH is within range. I changed doctors and was told that I have been treating the wrong condition, that is PCOS. This second doctor diagnosed endometriosis. How he diagnosed this without laparoscopy puzzles me. Can one have multiple gynecological conditions? It's very confusing, to be very honest.
Okay. Yeah, I think I got a bit lost in some of the question, but I'll answer the first part first. Yes, it's possible to have different conditions. There's a patient I'm taking care of. We did IVF. She has endometriosis, at the same time has polycystic ovaries. And that has been the best thing for her. The PCOS has helped her endometriosis because endometriosis tends to cause a lower ovarian reserve. It gives less eggs. But in her case, despite a lot of surgeries, because I found out when already a lot of surgeries had been done for her, which would have damaged her ovaries more and reduced her number of eggs, the fact that she has PCOS helped it as in getting a bit more eggs when you did IVF. She's currently pregnant. The first time miscarriage, second time is pregnant, which is a good thing. So I've seen it in quite a number of people. You get one ovary has an endometrioma, one has polycystic ovaries. I don't think that if one doctor had diagnosed polycystic ovaries and then another one diagnosed endometriosis, it might be that you have both. The other thing is that you also seem to have high prolactin, which sometimes can make one look like they have polycystic ovaries. It tends to give a picture of almost polycystic ovaries. So I think you need a real workup. What is your current prolactin level? Has it been controlled? Do a proper transvaginal ultrasound. Endometriosis, sometimes we can diagnose using scan by seeing endometriomas or even the history, okay? Premenstrual pain, okay? Pain that starts, we call it a premenstrual situation, and which is relieved by some of the drugs for reducing, like things like Visane, for reducing the deposits. So it's not a problem that they diagnose without laparoscopy. Laparoscopy would help in this case where it's a bit confusing, and if you're in a lot of discomfort, you can always go for a diagnostic hysteroscopy. I agree with you, you have a bit of a confusing diagnosis. It just needs to be worked up, and you could have all of them. So don't feel Maybe just also get another opinion. I know a tiebreaker, or go back to the doctor who diagnosed the polycystic ovaries to see. But sometimes you don't even need a label. Just sort out the particular problem. Is it pain you're having? Sort out the endometriosis. Is it fertility? Then if with all in that setting, you might need slightly more advanced than just tablets. You could try the other modalities for improving your fertility. And all the best in what you're doing. Over to you, Anastasia.
Yeah, thanks a lot, Dr. The other question is, can metformin cause kidney failure, or is it just a myth?
Sorry, you got cut off a bit, Anastasia.
Okay. Can you hear me now?
Yes.
All right. The other question is, can metformin cause kidney failure, or is it just a myth?
Okay. So any drug can cause any problem, and depending on what you already have. The main problem with metformin is actually more to do with the liver and lactic acidosis. These are drugs that you do not use. It's not good to self-prescribe. Even if you have talked about them in the presentation, it means that you still go to your doctor and work around them. If you have a kidney problem, you should be careful about some of these drugs. So I don't want to say it's a myth. If you already have a kidney problem, keep away from drugs until you've been evaluated. Anastasia, we have 5 minutes. I'm saying 5 minutes left.
Yeah, I can see. Yeah, I think we can try. So the next question is, I was given Spirulon for hirsutism. Does it help to reduce it?
Yes, spironolactone manages hirsutism. It is one of the drugs that can be used. It also has other, can help with the blood pressure and water retention. So maybe there's a reason why it is the one that was chosen and not any other. Yeah, but it does work. It's one of the drugs.
Okay. The next question is, what can I use instead of metformin because it has a lot of side effects on me, such as yeast infection?
Okay, great question. The main side effects are gastric. I don't know. The yeast infection could be an aspect of the hormonal disorder you have, and that needs to be looked at and treated properly. Minoxidil is a good insulin sensitizer that can be used. One of the ways of reducing the side effects of metformin is taking an extended release, the XR, and taking it to the meal and starting with a smaller dose. That is if you're talking about the gastric effects. If it's yeast, I have not encountered yeast infection with that. It also causes a bit of a running tummy sometimes. But metformin can be used to answer your question. And not metformin, minoxidil.
Okay, thanks. How long should one be on the various medications due to side effects?
Yes, that's a good thing. You know, I've seen people who take lots of drugs for a very long time, especially vitamins. Remember, some vitamins can also cause other problems taken long term, even allergies, poisoning. So work with your doctor. Do not overprescribe. But if it is a food supplement, then you can prescribe if you're taking cinnamon, if you're taking what are the other things we talked about? But anything that needs a prescription, work with your health provider. Ideally, by about 6 months, you should be getting the effect you require because you're working with other things. So they need tapering off and maybe a change if they're not working. Yeah, but work with a health provider. Don't self-prescribe unless it's a food supplement.
Okay, thanks, Dr. Is there a relationship between PCOS and cervical incompetence?
Sorry, you got cut off. PCOS and?
Cervical incompetence.
No, I think I'll just answer it short. No, usually it is not. There's no association at all. Those are two independent problems.
Okay, the next one is, what is your take on using herbal medication to treat PCOS? For example, arrowroot.
I'm big on herbals in a lot of this fertility and whatever, but arrowroot, a lot of my patients use it. Unfortunately, for herbs themselves, I'm not able to because I don't know the components. And my big take on arrowroot, which is very common, I've seen it help a number of patients and miss enough. So my take is that it is it is one thing that treats 100 conditions. People take Arorwet for fibroids, for PCOS, for endometriosis, for thyroid problems, for heavy bleeding, for infertility. So, and all those have different mechanisms. So I think what I would advise the Arorwet people or those who are taking is to get what specific, is there a dose for a particular condition, or is it everyone who can take it? I believe it helps quite a number of people, but it is not for everyone. I would beg not to get into that discussion of particular herbals, unless the ones that have particular names, because even Arorwet has components, we just don't know what they are. Maybe they have minoxidil, which could work, but they could also have many, many other things. Okay?
All right,
Say.
Daktari.
Mm.
So I have been having prolonged periods for 3 weeks now. What do I do to rectify that?
Simple answer, see your doctor, because prolonged periods, if it's due to PCOS, then maybe you had skipped a period and some periods, and then your lining is overheated. Progesterone could work, but again, maybe you got a pregnancy that miscarried and you need a diagnosis. So this is one case where I say, please visit your health provider, get a bit of a diagnosis, get at least a basic scan done, and rule out a pregnancy test, a pregnancy. Then maybe progesterone can be prescribed, but I wouldn't want to, it's not one drug that fits all bleeding problems.
Okay, the other one is, can I combine herbal medication with prescription medication?
Yes, you can, with working with the person prescribing the prescription drug, so that they know what you're taking. Some drugs counteract, so don't take herbals that we don't know what the components are with prescription medication and without your health provider knowing. Play it safe. I've seen poisoning. I've seen people who have been poisoned by combinations of a prescription of even supplements. Be careful. Remember, all of them have active components. They are really good, many of them, but used with caution.
All right, I know we, sorry, Dr. we are already at 10:01, but just to be fair, we started at 8:10, so maybe.
No, I actually don't mind. I was only questioning you because I think it will lock us out after 2 minutes. Is that the case? Is that the case?
No, it won't. Yeah.
Oh,
That's
I'm seeing a banner, 5 minutes left in your meeting, and I've seen it for a long time. I'm wondering how it's not moving. Yeah.
And
No, I don't mind.
it's just to okay. Thanks a lot for that.
Mm.
All right. So hello, Daktari. Does short cycles mean an ovulation? How can I track ovulation when having a short cycle of 21 days?
Okay, to answer that question, some people have normal cycles of 21 days. A lot of people and go on to have normal children, because remember, these people who ovulate, who have a 21-day cycle, ovulate after 7 days. But the other part, the one that we call the luteal is constant. It's always constant in everyone who has whatever number of days. It's usually 14 days. So that may not be the problem. However, there are some people with shorter cycles, especially less than 21 days, they are anovulatory, they have normal cycles. So if naturally you have a 21-day cycle, that should not give you infertility, and we need to find out what else you have. But most people with PCOS don't have such short cycles. So I wouldn't say straight up you don't have PCOS, but it's unlikely that you have a short cycle like this and you have PCOS. I don't know if I've answered the question, but I've tried.
Okay. So the next question is, can I conceive naturally even after a failed IVF cycle?
Definitely, yes. There's something that IVF seems to do. It seems to balance a bit of the hormonal things and give better eggs. I've seen a lot of people who have conceived after failed IVF cycles. Okay, you can, but that wave is maybe I would say a few months after. Even it also gives you time after a failed cycle. You need to recover financially. You need to recover emotionally. You need your body to, almost get a detox from all the hormones we give. Use that time, I continue making love and do whatever you need. But then, of course, don't wait for several years, or even after 6 months, that effect seems to go down. But I've seen a lot of conceptions. But remember, IVF is not 100%. Even when we cancel you, we tell you it will give you a chance based on your AMH, your age, and whatever other factors you have. It is never 100% in case someone cheats you. Even the centers that report 90%, that is not true. So it means that ideally you should try more than one cycle before giving up. Yeah, so I would urge, after a short wait where you're trying to recoup the money and to recover emotionally, try again, get back. Because if you went for IVF, it means that you have difficulties conceiving in another way.
Okay, thanks for that. The other one is, okay, where can I find you? What about your consultation fee? But I think that one you can address at the very end as we are closing the call. So, Dr. please explain, is induced cycle a normal cycle?
Okay, so by induced cycle, I am hoping we mean ovulation induction. Ovulation induction means, because a lot of people with hormonal disorders do not release an egg in a cycle, that's why they're not even having regular periods. We are giving drugs to sensitize the ovary to have a follicle start growing and mature to release an egg. And we can give tablets, and we can also give injections for this. When ovulation induction is done to get 1 or 2 good eggs, then you can conceive naturally. I mean, I hope that is what the question means, because natural cycle means, does it mean that you can conceive naturally? Of course, it's not natural because you've used a medication, but you can use that kind of induced cycle for natural conception, meaning you make love naturally and conceive. Okay? I hope, and I don't know whether Anastasia, you understand the question differently, but that is what I would think it means. Yes. So so when we induce ovulation, we can use it for timed intercourse. That is usually the first line of treatment. We induce and tell you, okay, you're going to be ovulating around this time. Go and make love. Let's say that you conceive. After three, four failed timed cycles, after normal ovulation using ovulation induction agents and natural conception, we try to do the same but with IUI. If that fails, then we can progress to IVF. So I hope I've answered that question.
Yeah, I think you have, but I think also maybe the question could also mean like maybe there's a time you come and you're given medication to induce a period.
Oh, no. Okay. So a period, remember, anytime you're having a period, you cannot be having any egg growing there. Usually a period is a time the cycle resets. Okay? It is like time 0. So time 0, and then now an egg will start being selected in the ovary by either naturally, by the normal FSH we have that is being produced by our brain, telling the ovary select an egg, or because we have given you medication that is helping increase the amount of FSH that will then select an egg. So during an induced period, you are not ovulating. But after that, you can induce ovulation. Yeah, Anastasia.
Okay. I got diagnosed with H. pylori and I'm on the second kit after the first one failed. I am wondering whether I should still continue trying to conceive before I heal the H. pylori.
Okay. My take on H. pylori, one, I think there's usually an overdiagnosis of H. pylori. If you are diagnosed at that time, please seek a different gastroenterologist to just make sure you're dealing with the correct thing. The number of drugs in H. pylori kit are so many that it would be unwise to try and conceive, because you know that you're pregnant only when you're already 4 weeks pregnant. So anytime you're taking a lot of medication is not the time to try and get pregnant. Wait until you're done with that treatment. Meanwhile, you can be trying to take the other antioxidants and then try to conceive after. Okay, and all the best in your treatment in H. pylori.
Okay, thanks, Dr. I think this other one is for you, Kibet. Is milk good for PCOS patients?
Now, in terms of the milk, remember milk there are two components that always will trigger the fat deposition. And when you look at this, we normally say there's something I mentioned before, that we need to try as much as possible to reduce the dairy products because we have fat content and lactose. And this fat content will aid in weight gain. And also the lactose, that one is a carbohydrates in milk, which will eventually increase your fat content. So the main key is how much do you take? I normally recommend up to around 300 ml per day. So if you're having like a cup of tea, maybe you can have a cup of tea maybe once in the morning, and that is enough. But don't depend so much don't reduce it, don't eliminate it completely, but take them in moderation. Thank you, Anastasia.
All right, thanks a lot. For you, Daktari, what's the best option for a person with one right blocked fallopian tube and ovarian cyst on the right ovary? And then what diet should I follow? But I think that the diet part, I think, was addressed earlier.
Okay.
Mm.
So those are two questions with a one. Okay, so we have a right blocked tube that is affecting the fertility, and then we have an ovarian cysts,
Yes.
which is a different concern, because ovarian cysts, we need to know whether they are simple cysts or they are complex cysts that could have problems. Is it a dermoid cyst? Is it whatever it is? For cysts, our main thing is to try and make sure that there's no cancerous component. So that needs to be addressed and investigated. But when it comes to fertility with a right blocked tube, you still have an option of natural conception if the right tube is the only one that is damaged. But what I've seen in most cases of tubal blockage, whatever caused damage in one tube, say it's an inflammation, an infection that blocked one tube, it tends to also affect the other tube as well. It might affect the hairs. So the other tube might not work as well, because we have tried a lot of things, natural conception with the other tube, timing, IUI timing to only when the other tube is the one, and you notice that the fertility of these people is reduced. So if it's been a while and you have one tube of blockage and it's not fertility is not working, then you can consider treatments that include IVF, where you avoid you're not relying on the other tube being open.
All right,
Okay,
thanks, Doc. I think,
so maybe you go for IVF or an evaluation. You can do a diagnostic laparoscopy to see that it's working okay. Yeah, but all the other treatments are important, can work.
All right, thanks, Doc. I think we'll take 4 last questions and then we can close the call. Then Dr. will give contact, maybe you can reach out. And then, so the next question is, how long should one be on metformin? Does it work the same as berberine?
Okay, yes, there's a herb called, there are many herbs. A new kid on the block is berberine. Berberine is an insulin sensitizer. There are studies that have compared berberine and metformin and found that they work as well. Berberine works almost as well as metformin in reducing insulin resistance without the side effects found in metformin. So if someone is on berberine, then maybe they don't need to be on metformin. All these insulin sensitizers, the effect is, as long as you're losing weight, you're reducing your insulin sensitivity, but a lot of them, you might need to take them for up to 6 months. Okay, so there are many different insulin sensitizers that are natural, including even our humble cinnamon, berberine, even melatonin, which is the sleep hormone, and other extracts, and N-acetylcysteine. Yeah, so at least 6 months as we try and work, because it should also be, there should not be over-reliance on supplements. If you're not losing weight while on a supplement, it still will not do much. It might not reduce your insulin sensitivity. If you're still having a poor diet, you're not losing weight, you're not losing visceral fat, you're not losing the central obesity, there's no exercise, the supplement might not work as well as it should. Okay, Anastasia.
All right, thanks a lot for that. Can someone conceive with high prolactin levels?
Rarely, and okay, so high prolactin, so depends on the level, because I've seen a lot of, when you do lots of tests, people, normal can go up even to 35 depending on the lab. Then you find someone has a level like 38. Another one has 37. You see, they're not very high because remember there are other factors that can increase the prolactin mildly, like stress, lack of sleep, touching on the breasts, the time of the cycle. So if it is less than 50, sometimes we want to repeat before even we diagnose the person as having hyperprolactinemia. But I found most of our clients are in a hurry and want treatment straight up. However, if it is a high enough level over 50, then it's very difficult to conceive. And if you conceive, there might be higher chances of miscarriage. So it is important to treat the high prolactin, and it's very easily managed. These days, there are drugs like cabergoline that are taken once a week. But the problem why most people don't sort out their hyperprolactinemia is that they stop taking the drug prematurely. Once the level is normal, you should continue on the same dose for more than 3 months, at least 3 months, to suppress the hyperprolactinemia, the prolactinoma, the gland that is producing the high prolactin. So please get that sorted out because it can affect implantation as well. Over to you.
Okay, thanks a lot for that. The next question is PCOS the cause of my prolonged food regurgitation?
Yeah, could be. Remember, people with PCOS tend to have a bit of central obesity, high BMI. Remember, a lot of people with reflux, it could, and a lot of people with esophageal hernia, or the duodenal hernia, whatever they are called. I'm trying to remember the name. The hernias. Also, obesity is a risk factor. So there could be that association, and that needs to be looked at. The gastroenterologists or even the gastrosurgeon will advise on whether you might need just medication even as you try to lose weight, or you could need a surgical procedure like Nielsen's fundoplication for the very extreme cases. So good to seek health opinion of a gastroenterologist as you try to lose weight.
Right. The next question is, I have poor quality eggs. How can I improve them?
Sorry, I missed part of that. I have
poor quality eggs. How can I improve them?
Okay, poor quality eggs could be, the main reasons could be age. The other one could be things like PCOS. And I don't know, so is it after IVF that they were told that they are poor quality eggs, but antioxidants could play a big role. If it is an age-related factor, might be difficult, but there are many antioxidants, things like CoQ10 have a big role. Things like melatonin have a big role. Yeah, those super antioxidants have a big role. Optimum weight, reducing your insulin resistance has a big role in improving the egg quality. But I think that it's a specific, it has a lot of what ifs that I am not able to answer. That can be a one-on-one because I don't know in what setting they were told they have poor eggs.
All right, thank you. Is metformin given to every PCOS patient? Because I know there are people who are not obese and they're given metformin. So is it given to every PCOS patient?
Not every PCOS patient, but commonly to patients with a bit of obesity or any time when you find glucose insensitivity, insulin resistance or abnormal glucose tolerance. But in many cases, we sometimes give it even in slender patients because remember they have a lot of visceral fat. Yeah, so it's a one-on-one. We said please don't self-prescribe glucophage. It's a one-on-one, and there must be a reason why it was given to a slender patient.
All right, thanks for that. The other question is, what might be the reason for miscarriages at exactly 5 to 6 weeks in a person with PCOS?
Okay, so people with PCOS have a few problems that affect that cause miscarriages. The first one is the egg quality. We say it because of the egg quality, they could have aneuploidies. So aneuploidy means imbalanced chromosomes in the embryo. So that embryo, even if it implants, might then end up not persisting. That is the first thing. The second thing, they have hormonal disorders. Remember, most of them have progesterone insufficiency. the luteal phase insufficiency, so they don't have enough progesterone after ovulation. So one thing we do when people with PCOS conceive, we put them on what we call luteal support, some progesterone to support that first part before the placenta takes up making progesterone, which then supports the pregnancy. So that's another common cause of miscarriages. The other one is the metabolic factors. Most of them have glucose intolerance and other issues which could affect implantation. Okay, and that is the same reason they even have higher cases of preeclampsia, diabetes, and such. So there are three reasons. So all of them need to be addressed. Sometimes we just throw everything at it until you get a solution, because you might not have a particular test that will tell you exactly what is wrong. But by trying to improve on the egg quality, giving progesterone support immediately after implantation, giving some blood thinners and things like that, and optimizing before pregnancy, then can win that battle.
Okay, Daktari, what are the do's and don'ts after embryo transfer through IVF process?
Wow, that's it's a very big question. Now, there are lots of myths. Let me just say, I've had the pleasure, or can I say, maybe I don't know, of training in places where I trained in India. Part of my fertility training was in India, and I've also trained in Europe. So I'll give you the two scenarios so that you know. In India, the do's and don'ts are like 30. Don't shower, don't wear high heels, don't eat pineapple, don't eat, I don't know, beet, don't take spicy food, don't wear perfume, don't, don't shower. And I've seen some IVF centers, especially run by people of Indian descent, have all those do's and don'ts. Then in Europe, where people don't have nannies and they have even other babies to take care of, there's almost nothing apart from maybe don't take medication that can affect. Okay, there are no special foods, there's no bed rest. The lady leaves, she comes with her other baby who is waiting, they're waiting for transfer, and they go shop and go home. And she'll make dinner, she'll cook, clean up, and she still gets pregnant. And studies have been done, and it's been shown, apart from the very short waiting period of maybe like 10 minutes or 20 minutes after the embryo transfer, a lot of the other things have not been found to be useful in implantation. But I tell people, if the person who has done your embryo transfer has given you a list of 30 things, including don't get out of bed for 2 weeks, unfortunately can lead to DVT, or you've been told not to shower. If I tell you to do those things, you're going to psychologically feel like you failed your pregnancy because you did them. So just follow them. But if you come, someone like me, and I don't have a lot of do's and don'ts, and you still get pregnancies, then follow anything else your heart tells you, what you have studied. But basically, there's no particular thing that those do's and don'ts do in terms of success in IVF. I hope I'm not confusing more than you are.
Thanks a lot, Daktari. I think there are only 3 more questions on that. Guys, don't add any more question. We'll just tackle these 3. So how long should one take carbapenem or something like that to lower prolactin levels? Is a year too much?
Okay, that's a good question. So carbapenem is tailored, what can you say? We use like a stepladder approach. Okay, we titrate it. So initially we'll start you on once a week, then 0.5 milligrams, maybe once a week or twice a week. Then we measure the level again after between 4 to 5 to 6 weeks. We find it's not gone down. We double the dose until we get, so that process could take a bit of time until we get the accurate dosing. And then once you have found the dose that works, you need to suppress that for at least 3 months. If someone has failed before, you can even go even up to 6 months because you want to shrink. Prolactin is produced by an overgrowth in the pituitary gland called a prolactinoma. The carbapenem drug can't shrink it. Now, people who have beyond a particular level and it's not going down, they're going to a whole year, they need an MRI to just find whether the tumor is very big. Unfortunately, some people might need even surgical removal of that part of the gland of the pituitary, which is a brain surgery, which people don't want to do. So if it takes a year to shrink it without and by avoiding surgery, then so be it. So it is not too long. It just means that perhaps it's a very severe case of hyperprolactinoma and you need it that long. Please work with your gynecologist and your endocrinologist if you're having challenges in managing this. Okay,
Okay, the
Anastasia?
second last question. So why do my breasts produce a bit of milkish discharge and my prolactin levels are normal?
Okay, a lot of women who have ever breastfed or who have been exposed to estrogen, remember, estrogen has a role in making the alveoli grow, and then some maturation occurs with the progesterone. So any woman can produce a bit of milky discharge. So if your prolactin levels are normal, do not worry. Do not just get a breast checkup. If there's no mass like a galactorrhea or something, then so be it. Your breast could be more sensitive to the estrogen hormone. Even pills make people produce a milky discharge. So just get the whole checkup done, breast check, and a repeat prolactin hormone to just confirm. And then you can forget about it.
Okay, thanks. The last question is, how many months are good for preparing an egg before you go for conception trial to avoid miscarriages for people with PCOS, and how best can you prepare?
Okay. So there's no particular limit. So say you have a very severe insulin resistance, quite obese, ovulation induction is not working in simple terms, and you have to go, your BMI is 45, so that even if you conceive, you might have other challenges, and you're young, okay, hoping you're not almost at the end of the reproductive age, you're not 43, and you're young, you still have a bit of time, and it might be worth investing in this until your BMI is closer to normal, your insulin resistance is closer to normal, and you've taken antioxidants at least for 3 months, then you could try. But it's a very individualized answer to anyone here. So if you have 100 people, there could be almost 100 different types of scenarios for all of them, and one answer will not fit all. Do not take the solution for your colleague who's in the group or that you know about and apply it to yourself. You need to get yourself evaluated and see whether whatever measures are being done for that person would work for you. And be open-minded. That don't say, oh, this one was taking this and it worked for them. It might not work for you. Or this one just took 2 months and then she got pregnant. What if it's not the best for you? So just work with your health provider, work with your gynecologist, your fertility specialist, and see what works. And even your nutritionist, but especially if you're obese.
Wow, thanks a lot, Daktari. Me, I've learned so much today. Guys, I hope you've learned something and you've carried actually a lot of questions that we normally ask
They're
in the
losing
group,
you. I
and
don't know. I
there's no
think you're
one. Oh, it's my network. Oh no.
yeah.
Sorry for that. So
It's okay.
I was thanking you for the session. It was great. We've learned a lot. What I wanted, maybe you can tell people where to find you, how to reach out. Yeah.
Okay, you got cut off a bit, but I think I got most of the question. Thank you, Anastasia, for the invite. Thank you, Kibet, for the short notice and coming and giving. I learned a lot, and I'm going to continue seeing you. Luckily, most of you can't see me. I think I must have a bit of insulin resistance. We need to work on that. Very informative. Thank you to the participants. Very engaging and very good questions. And thank you for staying on. I'm Dr. Jane Machira. I'm a gynecologist, fertility specialist. I'm found in 40 Suits. You can reach me on the number. I had put my number on the, let me see. Yeah, that's my number, 0722659399. You can call me. Sometimes if I don't pick, it goes to the reception. I'm in 40 Suits Gynecare, which is on 7th floor. But I'm also in Capital Gynecology. That's where I'm seated right now because there's less traffic and the very good Wi-Fi connection. So we have an office on second floor called Capital Gynecology in the same building, 208. So, but you can reach me on the number and I'll see you wherever I am. It's just in the same building.
Thanks, Doc. You too, Kibet. Maybe you can tell us where to find you.
Okay, thank you so much. You can find me with Dr. Jane Machira at 40th Street. Also, you can contact me by 0720 663113. Thank you so much.
Maybe you can repeat that again a bit slowly. Kibet, we didn't get that number.
I think they did disappear. let me read for you his
Sorry.
number. Oh, okay, Sarah. Okay, okay.
Sorry.
Kibet, just read it.
My
Okay.
phone. Okay, my phone number is 0720 663113. 0720 663113.
Yes, now we
Basing
got
on
it. Yeah,
all
yeah.
measurements. Okay, thank you.
Yeah, we got it this time. So thanks a lot, Daktari. Thanks a lot, Kibet. Thanks a lot to all of you guys for participating on the call. I believe we've learned a lot. Those are the contacts of both Dr. Jane Machira and Kibet. So I'm going to share the recording so that you can always refer to it later after this call. And thanks a lot, Daktari. This was really, really helpful. I know we took a lot of your time. We appreciate sharing the knowledge with us. We usually have so many questions that are left unanswered, and I feel like at least we have been able to learn something today. So asante sana. And thanks a lot, guys, for joining the call.
Okay, perfect. Thank you. Have a good day. Happy holidays.
Same to you. Happy holidays.
Okay.
Thank you.
You're welcome.